questions at the end. So to start us off, we've met Nyaradzo. She chaired the previous session. So Nyaradzo is a clinical pathologist who has a lot of experience in HIV prevention trials. She's a member of several research committees, including those funded by NIH, and she's a co-chair of several international research groups and a member of advisory boards of several committees in Zimbabwe and the region and internationally. So she's from Zimbabwe, and we are honored to have you. So Nyaradzo, you are welcome. Please start us off. Thank you.
Thank you. So thank you very much for the kind introduction. So yes, my name is Nyaradzo Mgodi from the University of Zimbabwe. I'm going to be talking about the role of long-acting antiretroviral drugs in HIV prevention. So there are always pros and cons to presenting last. The disadvantages is that people are tired, but the major advantage is that by the time you get to your presentation, everything has been covered, so you can just like skip every other slide, yeah? So this morning, Michelle Venter, she talked about how art has revolutionized HIV treatment. We in the HIV prevention method field, we also say that art, antiretroviral drugs, have revolutionized HIV prevention. We know that a lot of efficacy studies in terms of HIV prevention, they've been done, and they show a clear dose-response relationship of protection and adherence. So you are only protected if you take the drug. And I think this has been said so many times this morning, this afternoon, the role of adherence in protection, prevention for HIV or treatment. Yes, I'll come to oral PrEP in a bit, but we know that daily oral PrEP in the form of Truvada, for example, has revolutionized pre-exposure prophylaxis, but it has fallen short of expectations. 1, suboptimal uptake. 2, low persistence rate. In areas where the uptake is good, persistence is low. But the major shortcoming is adherence. For the many at-risk populations, daily oral PrEP has been a major problem. And we know that adherence to therapy is inversely related to the dosing period. So the shorter the dosing period, the less one is likely to be adherent. Yeah? So we need sustained release or long-acting formulations, which we see holding significant promise for increasing adherence and increasing effectiveness in pre-exposure prophylaxis. This is an old study, but this is coming back to the beginning. Here we see that oral pre-exposure prophylaxis, I've talked about the dose, the clear dose-response relationship. If you look at the graph here, these are the earlier studies we did. I worked on voice, we didn't start FemPrep, but these studies showed that effectiveness is dependent on adherence. So the more adherent one is, the more effective. So this, in a nutshell, it just means oral PrEP or PrEP in a nutshell works when it's taken as prescribed. And we know that oral PrEP, it's modeled to be 99% effective when taken 7 days per week as prescribed. That's in women, cisgender women. But we know that protection against vaginal exposures is modeled to be much less forgiving. So for women who, like here in Africa, in sub-Saharan Africa, 90% of HIV infection is through heterosexual intercourse. So for women who acquire HIV through vaginal exposures, they must take at least 7 doses to be protected. Yeah, so coming back to long-acting HIV prevention formulations, we are working on many formulations to overcome barriers, the barriers mainly of adherence, which has been presented by daily oral therapy. And I think this has already been discussed. The field of long-acting injectable agents, really that field is substantial precedence among Antipsychotics, for example, flufenazine decanoate is an antipsychotic. Contraception, we've just been talking about DMPA. Antibiotics, kanamycin, for example. So this has got a long precedence. We do not need to reinvent the wheel. We know that long-acting formulations work and that they are acceptable. And we also know that there are removable depots of contraceptive agents, for example, gel, no plant, yes, and some transdermal patches for sustained drug delivery. And these are highly popular, not just acceptable in my setting, but highly, highly popular. And they require less than daily dosing intervals. However, these long-acting agents may be limited by their molecular size and chemical properties. Some of them are really hydrophobic, so it makes them, they are limited. So this drug development field is highly dynamic, and it's working to improve the favorable characteristics of nanoformulations, prodrugs, and devices. Yeah, so I'll talk about some of these here. So here I'm summarizing what I'll talk about. I'll talk about some injections. I won't be able to go through all this, but this is just to show you some of the technologies that are available for drug delivery, whether it's for HIV prevention or even HIV treatment. So here you can see the long-acting depot injections. There are novel oral formulations. One can wear an infusion pump. I'll talk about the vaginal ring. I'll talk about the subdermal implants. And if time permitting, I'll talk about microneedle drug patches. So really, these are the new drug delivery systems, and they promise to revolutionize long-acting antiretroviral therapy, as we've heard in the morning, and as well as antiretroviral-based prevention. So like any product, there are pros and cons, there are advantages and disadvantages. And I liked that Francois had already started talking about some of the disadvantages, which I've listed here in red. But the advantages really improved product profile in terms of long-acting prevention formulations. They've got a potential for greater adherence. They are less user-dependent. They are safer. We talked about drug-drug interactions. We talked, I think someone talked about first-pass metabolism. So long-acting drugs, they've got less of these side effects. They are more effective, they are more forgiving, and they are more compatible. I work every day, I work with women in sub-Saharan Africa. They are more compatible with women's lifestyles. And they've got a longer duration of protection, follow-up visits, less social and logistical challenges of pills. I was listening to Dr. Dungu, and I was thinking, if this patient had had an injectable, at least she during the lockdown, she could have had some doses. So there are less social and logistical challenges of pills. Yeah? Removable implants, for example, we all know about the long tail of Cabotegravir. So removable implants, they avoid this long tail phase. Biodegradable implants, they avoid removal procedures. But one of the major shortcomings of long-acting prevention formulations is that they must be clinician administered. Yeah, and sometimes, depending on the drug, especially Cabotegravir, for example, sustained systemic exposure results in AEs and injection site reactions. How do we manage missed doses? How do we manage the long PK tail? Those are some of the questions we need to answer. So I will not spend time on this HIV life cycle, but it is just to remind us as we talk about antiretroviral-based prevention, we need to remember the HIV life cycle so that we see where the type of drug is acting. And I know I'm preaching to the choir here, I'm preaching to the converted. You all know the HIV life cycle. So coming back to long-acting slow-release formulations, already work has started, and in my presentation I'll talk about Cabotegravir, which has been talked about. I'll spend a bit of time on Dapivirine and Islatravir, Lenacapavir. I will not talk about VRC01, but It's one of my babies, where this was a proof of concept study, where we showed that this is the first ever study to demonstrate that passive immunization of broadly neutralizing monoclonal antibodies prevents HIV to strains that are sensitive to it. Yeah, so these are just old studies of Cabotegravir, long-acting injectable Cabotegravir. We've come a long way. So many studies have been done on Cabotegravir, looking at the safety, tolerability, pharmacokinetics, and so forth and so forth. These are the earlier publications as early as 2017. Yeah, so just as a reminder, we've heard about this. Cabotegravir is an INSTI inhibitor, and is structurally similar to dolutegravir. It has got a high barrier to resistance and is highly potent. It is available as an oral formulation, which has got a short half-life of 40 hours, or a long-acting injectable formulation, which is comprised of active drug nanocrystals. And this is the one we use for HPTN 084, and HPTN 083 has got a plasma half-life of up to 50 days. So I was going to show this, but Diego, maybe he can assist. I was going to show this because I give a lot of talks to our CAB members and to communities, but this is just a reminder of the HIV life cycle, where we have binding, where we have HIV RNA, and here comes the reverse transcriptase, and we've got DNA, and then we come to splicing. Yes, it's a bit slow, but this is, normally I just use this for community members. So once, so we've got the integrase helping with splicing. Let's move on to the next slide, please. So that's what happens when there's no Cabotegravir. So now the viral DNA is integrated into the host DNA. Next slide, please. Or can I move from here? Yes. So now when we've got Cabotegravir, which is an integrase inhibitor, these animations, we've seen that they work a lot when we are doing community engagement, because the life cycle is highly, highly complex. So now when there's Cabotegravir as pre-exposure prophylaxis, the HIV life cycle will start with binding, fusion, and then we've got reverse transcriptase, we've got HIV DNA, which is going to be formed just now. So the DNA, we now have HIV DNA. So now comes the crunch. Instead of splicing, that doesn't happen because we've got Cabotegravir, which is an integrase inhibitor. Yeah? So I'll just move, next slide, and then I'll control from here after that, yeah? So that's really the animation of Cabotegravir. So I'll come to HPTN 084, which is a study that we did in sub-Saharan Africa, and some of my colleagues are here. We did this in 7 countries, including Zimbabwe and Uganda and other countries. So this was a multi-center, randomized, double-blind, phase 2b/3 trial in participants without HIV. So we did HPTN 084. This was a superiority study in cisgender women. The brother study, HPTN 083, was a non-inferiority study comparing the safety and efficacy of long-acting Cabotegravir to oral TDF-FTC. So this had a complex study design with an oral lead-in phase for 5 weeks, and then when participants were deemed safe to go on to the injectable, they moved on to step 2, which where they received long-acting CAB or placebo, normal saline plus TDF-FTC once daily. And stage 3, participants were all supposed to move on to open-label Truvada. And our primary endpoints were looking at HIV infections in steps 1 and 2, and grade 2 or higher AEs. So I'm sure everyone knows these results. We had 40 infections over 3,892 person-years, and the pooled incidence was 1.03 per 100 person-years. In a nutshell, what our results, what HPTN study showed is that there was an 80%, 89%, almost 90% lower risk of HIV infection among women on CAB-LA versus oral Truvada. So this study showed that CAB is highly, highly superior to Truvada, and with high levels of protection. I've talked about the types of populations. In 084, we looked at cisgender women. So these results really, they mark the first time ever, a systemic long-acting form of HIV prevention has been demonstrated to be highly effective. And in December 2021, the FDA approved CAB-LA as pre-exposure prophylaxis, and this is the first ever injectable to be added to the toolbox of proven HIV prevention methods: the condom, oral PrEP, the Dapivirine vaginal ring, and I anticipate that there are many others coming. Yeah? But now that we've got these beautiful results, we need to conduct implementation science to ensure the feasible, affordable strategies for delivering injectable Cabotegravir. What about uptake, adherence, end-user engagement? I was happy that Dr. Barbara talked about end-user qualitative studies. We must never forget engaging the end users, the stakeholders, and the service providers. Yeah? One of my most favorite topics is the monthly vaginal ring. This is long-acting PrEP formulated as a flexible silicone ring. It's a soft, malleable ring made of silicone, about 5 centimeters in diameter. It slowly releases the antiretroviral drug Dapivirine over 1 month, and it is modeled similar to how hormonal contraceptives are done. This is a woman-initiated and controlled method, self-inserted, does not interfere with menses, does not interfere with sexual intercourse, and this is the first ever pre-qualified long-acting product in the HIV prevention toolbox. Francois in the morning talked about cold chain. The ring can be stored at room temperature with no requirement for cold chain. It's got a 5-year shelf life, and it's highly scalable. And I'm proud as a Zimbabwean that Zimbabwe were the very first country ever to approve the ring for use. And recently South Africa has just approved it. And there are regulatory reviews. They are pending in many other African countries. So I won't talk about the trials that we did to come to this stage, but we did the Aspire studies, DREAM, HOPE, the open label studies, and the ring study. These were done in Malawi, South Africa, Uganda, and Zimbabwe. So these were some of the pivotal trials that led to the pre-qualification of the vaginal ring, to its registration as the first ever female-controlled HIV prevention modality. And really, stakeholders are really optimistic. I won't go through this, but there's so much enthusiasm about the ring. Yes, policymakers, there's a lot of work by the Mosaic group looking at how to roll out Cabotegravir and how to roll out the Dapivirine ring. Already work has started on next generation intravaginal rings. Conrad's tenofovir and levonorgestrel 3-monthly ring is the most advanced multi-purpose prevention technology intravaginal ring. It is planned to protect against HIV, HSV, and pregnancy. Yes, so it is the most advanced, and I won't spend much time there. This morning we heard about islatravir, so I will not spend a lot of time, but this is a first in-class nucleoside reverse transcriptase translocation inhibitor, and it's got multiple mechanisms of action. So when I showed the life cycle of HIV, islatravir targets many of that many of the stages of HIV life cycle. And it is highly, highly, highly potent against HIV-1, against HIV-2, and many other multi-drug resistant variants, and it is 10 times as potent as any previous HIV drug. So small doses are effective, so it lowers the risk of side effects. It's got a high barrier to resistance, and it is there's a slow release yearly implant which was already under development. But like what Francois said in the morning, the FDA put a clinical hold on the islatravir development program in December of 2021 because of safety issues regarding lymphocytopenia. Yes, so we had to stop the Empower 022 trial that we were planning for in cisgender women, as well as the Empower, the brother study, Empower 24 study. Yeah. So another drug which is also in the development for long-acting formulation is lenacapavir, which is a capsid inhibitor. Yes, and it also is highly potent, and it works against multiple HIV strains, especially the drug-resistant strains. Already there's a subcutaneous injectable formulation which displays a long half-life. Yes, but also development or work on lenacapavir has been put on hold by the FDA in December of 2021, not because of safety concerns, but because of logistical issues in terms of the vials, the reactions in the vials. Yeah. So these are some of the next generation implantable drug systems. Here we've got Oakcrest is working on a non-degradable pod type. This is a tough implant. We can have a refillable transdermal nanofluidic implant, a non-degradable mini pump implant, a biodegradable reservoir TAF implant, a subdermal pellet system, I'll talk about this just now, and a non-degradable reservoir CAB implant. This is the Northwestern University. This is a collaboration, SLAP HIV, Sustained Long-Acting Prevention Against HIV, working with Northwestern University on this non-degradable CAB implant. So the subdermal pellet, I've talked about this. It's biodegradable, so there's no need for removal. Flexible dosing, suitable for busy, limited resource clinic. Someone talked about having thousands of patients. I also have many women who need HIV prevention. So if this is easy to insert, it becomes highly suitable for settings like mine. Here's another example of an implantable thin film polymer device, which is also user independent and is biodegradable. It's a subcutaneous implant. So HIV prevention, really, we are piggybacking on the successes of contraception. What contraception did well, we are doing it well and improving on that. Yes, and these are other novel drug delivery systems. I'll just talk about the intrauterine device. This is the copper T with copper here for pregnancy prevention, and the ARV will be infused into the stalk of the T. So this becomes a multi-purpose prevention technology intrauterine system. There are injectable depot systems, microarray needle transdermal patches, mini pill boxes, some electrospan nanofibers, some insets. This field has really just exploded with many, many drug delivery systems being looked at in preclinical development pipeline. What this means is that women will have choice so that no one ever gets HIV. Everyone can have a choice to prevent HIV. So in summary, we've heard throughout today that daily regimen for HIV prevention and treatment remain a surmountable barrier to adherence. We know that long-acting antiretrovirals may improve adherence to therapy and extend opportunities. Yes, and we know that daily adherence to oral regimen will be replaced by longer intervals between clinics. And these modalities will allow a wide variety of options for pre-exposure prophylaxis. But despite having these good products, we need a supportive organizational and policy environment to allow rigorous national scale-up of the Dapivirine ring and long-acting Cabotegravir. So with that, I say thank you. And I'd said to myself, I would like to see, I hope everyone watched Wakanda. I've used this slide in the past where I said this is very much like a multi-purpose vaginal ring, and I think it's the same. So kudos to the mythical state of Wakanda, which has empowered women. And I always think that Wakanda is as beautiful as my home country, Zimbabwe. Thank you.